Hello, and a huge welcome to all our focus learners out there joining me for this explainer. Today, we're mapping out an incredibly fascinating journey. We're going to trace the pathway from microscopic mast cell biology all the way up to clinical diagnosis and treatment for conditions like urticaria, angioedema, and allergic rhinitis. Honestly, if you've ever wondered how the immune system works and, sometimes seriously overworks, you are absolutely in the right place.
I mean, think about this for a second. What actually transforms a simple, minor physical scratch on your arm, or even just a sudden drop in ambient temperature, into a cascading, full-blown systemic reaction? How does the body's own defense system suddenly create allergic chaos in the skin and the mucosa? It is a remarkable, albeit sometimes super frustrating, biological process. And the answer to all of this lies within one highly specialized, fiercely protective immune cell.
So, to figure that out, here is our cell-to-clinic roadmap for today. We'll start with number 1, meet the mast cell. Then 2, mast cell mediators. 3, urticaria versus angioedema. 4, inducible triggers. 5, diagnosis and guidelines. And finally, 6, pharmacotherapy. Let's get right into it.
Section 1. Meet the mast cell, the immune sentinel. Okay, so here's our main character. It's a bone marrow-derived immune cell. But unlike most other cells of bone marrow origin, mast cells actually circulate as committed progenitors, meaning they lack their characteristic secretory granules at first. Now, what's really unique here is that they express a receptor called KIT, which interacts with stem cell factor, alongside another receptor called Fc epsilon Ri. And unlike most other immune cell lineages, mast cells actually retain and increase their KIT expression as they mature. Think of them kind of like an armed guard, taking up a position at the borders of your body, in your skin and your mucosal tissues, just waiting for a threat to cross their path.
Moving on to Section 2, mast cell mediators, preformed versus synthesized.
Let's peek inside the cell's armory, starting with its preformed grenades. The mast cell stores these in beautiful crystalline secretory granules. Now, when an allergen cross-links that IgE antibodies bound to the mast cell surface receptors, it triggers this immediate solubilization and swelling of these granules. Within just one single minute of receptor perturbation, the cell undergoes exocytosis. It literally throws these chemical grenades right into the surrounding tissue. And that payload? It includes histamine, which causes rapid vascular dilation and permeability, as well as acid hydrolases and some highly specific neutral proteases like tryptase, chymase, and carboxypeptidase A. This right here is the immediate hypersensitivity response happening in real time. But wait, the mast cell doesn't stop there, and this brilliantly illustrates just the sheer adaptability of our immune system. It can also synthesize entirely new lipid weapons on demand through an exact enzymatic cascade. Here's how it works. Step 1, calcium-dependent phospholipase A2 releases arachidonic acid straight from the cell membrane. In step 2, the cyclooxygenase pathway converts this into prostaglandin D2. This is a powerful mediator that promotes even more tissue recruitment of inflammatory cells. Concurrently, in step 3, the 5-lipoxygenase enzyme, aided by an activating protein we call FLAP, creates cysteinoleukotrienes, specifically LTC4, LTD4, and LTE4. These leukotrienes are incredibly potent smooth muscle constrictors. We're talking far more potent than histamine itself. All right, Section 3, urticaria versus angioedema. Let's look at the clinical differences.
Zooming out to the clinical level for a minute, the absolutely crucial point to understand is that urticaria, which you probably just know as hives, and angioedema are actually similar pathophysiologic processes, but they're occurring at completely different levels of the skin. Urticaria involves the superficial dermis, and because of that shallow location, it's intensely pruritic, meaning incredibly itchy. You'll see these well-circumscribed wheals with blanched centers that kind of migrate around, and they usually last less than 24 hours without leaving a mark. Angioedema, on the other hand, originates way down in the deep dermis and subcutaneous tissues. Because it's deeper, the swelling is dramatic, it presents with much more pain than itchiness, it has very minimal surface redness or erythema, and it can take hours or literally days to finally resolve. We also have to classify these conditions by their timeline. Acute attacks, which are often triggered by a specific food, a drug, or maybe a viral infection, those resolve in under 6 weeks. But if the disease persists beyond 6 weeks, we designate it as chronic. And what's super fascinating here is that up to 45% of patients with chronic urticaria actually have an autoimmune cause driving their disease. They develop autoantibodies directed either against their own IgE or directly against the alpha chain of that Fc epsilon Ri receptor on the mast cell itself. So their body is essentially tricking its own mast cells into firing. Wild, right? That brings us to Section 4, Inducible Triggers, the physical stimuli. Notice the really distinct hashtag pattern here. This demonstrates something called dermatographism, which literally translates to skin writing. Affecting roughly 2 to 5% of the population, a brisk stroke with a firm object over the skin creates this exact linear wheal and flare swelling within minutes. The mast cells are actually degranulating directly in response to mechanical shear force. And dermatographism isn't the only physical trigger out there. Let's walk through some of these other fascinating clinical vignettes. Imagine you go for a run, or you step into a really hot shower, raising your core body temperature. Well, for someone with cholinergic urticaria, this triggers intensely itchy, tiny 1 to 2 millimeter wheals surrounded by massive red flares. Then there's cold urticaria. Imagine jumping into a freezing cold swimming pool. The sudden drop in temperature causes massive, localized mast cell degranulation, and that can actually progress to full vascular collapse. We also see pressure urticaria from sustained force, like wearing a heavy tool belt all day, and even solar urticaria, where specific UV light spectrums trigger wheals solely on sun-exposed areas.
Section 5, Diagnosis and Guidelines, the clinical workup.
Now, you might expect a massive battery of complex lab tests for such a dramatic disease, right? But actually, according to modern practice guidelines, the primary diagnostic tool is simply a highly detailed patient history and physical exam. For the vast majority of chronic urticaria cases, first-line laboratory testing is either strictly limited, maybe just a basic blood count or inflammatory markers, or it's not recommended at all. However, atypical features demand immediate attention. If a lesion lasts longer than 36 hours, if it's painful rather than itchy, and it leaves residual bruising or scarring, well, that is a hard indication for a skin biopsy to rule out a much more serious condition called urticarial vasculitis.
And what if a patient presents with isolated angioedema, meaning deep swelling with zero urticaria and absolutely no itching? Clinicians have to suspect something else entirely, a bradykinin-mediated process. A classic example here is hereditary angioedema, or HAE. This is an autosomal dominant disease caused by a mutation in the SERPING1 gene. That mutation leads to a deficiency in the C1 inhibitor protein, causing a massive overproduction of bradykinin. Bradykinin opens up the blood vessels, sure, but it doesn't trigger itch. Instead, it frequently causes severe, painful gastrointestinal colic, or, most dangerously, rapid swelling of the airway.
Okay, final stretch. Section 6, Pharmacotherapy, Step-Up Treatment.
For managing standard urticaria, we rely on a structured step-up therapeutic ladder. Step 1 is super straightforward. Initiate second-generation, non-sedating H1 antihistamines like loratadine or cetirizine. If the patient's mast cells are still misbehaving, Step 2 allows clinicians to safely increase that antihistamine dosage up to 4 times the standard daily dose. If symptoms are still persisting, we move to Step 3, adding targeted biologics. A fantastic example is omalizumab, which is a monoclonal antibody that binds up IgE, effectively disarming the mast cell. Alternatively, heavy-hitting immunosuppressants like cyclosporin can be used. Noticeably absent from this latter, systemic glucocorticoids. While they work fast, they're generally avoided for chronic use due to severe long-term toxicities. Now, for the bradykinin-mediated chaos of hereditary angioedema, standard antihistamines are completely useless. But modern medicine has advanced incredibly far here. We can now provide HAE prophylaxis by directly replacing the missing protein using plasma-derived C1 inhibitor, or by using monoclonal antibodies like lanadelumab or drugs like berotalstat. For acute attacks, we deploy targeted rescue drugs like icatibant, which blocks the bradykinin 2 receptor outright, or ecallantide. Finally, for those with specific allergic triggers, allergen immunotherapy can desensitize the immune system over time using subcutaneous or sublingual delivery. But there is a massive clinical warning here. Patients on beta-blocker medications face a severely increased risk of life-threatening anaphylaxis during immunotherapy, making it a strict contraindication for many. All of this brings us to what I think is the ultimate medical paradox. We possess this incredibly sophisticated immune system, guarded by these hypervigilant mast cells, equipped with preformed chemical grenades and synthesized lipid weapons. They literally spent millions of years evolving to protect us from pathogens and toxins. It's a really delicate balancing act between necessary defense and allergic chaos. If our immune system is this incredibly sophisticated, why does it still misfire so easily against a cold breeze, a firm scratch, or our own autoantibodies? And what will it take for modern medicine to finally master this delicate balance? Thank you so much for exploring this explainer with me today, and keep asking those big questions.